It's an honor to be speaking in front of an audience who is far more experienced in CAGB and especially in an audience whose researches and literature also I'll be referring to. So the topic of my talk is role and extent of lymphadenectomy in carcinoma gallbladder. To emphasize the role of lymphadenectomy in carcinoma gallbladder, I'll first like to put up my first two slides. One is obviously where our previous two speakers left on, that the importance of R0 resection cannot be exaggerated. R0 resection is very essential. But even when we look at patients who have an R0 resection, we find that those patients who have nodal disease have significantly poorer survival as compared to those who have nodal disease. So this is my, shows that nodal lymphadenectomy is essential even in R0 resection to actually prognosticate. This is my second slide to show the importance again. In this article, they had 1,406 patients, of whom 907 had not undergone any lymph node removal. The others, 499 had undergone a lymph node resection, but they were N0 disease. They found that those patients who had not undergone any lymph node resection had a disease-free survival of just 15 months, compared to those patients who had 1 to 3 regional lymph nodes removed, where the disease-free survival had significantly increased to 40 months. And obviously, the disease-free survival improved to 47 months with more than 4 nodes removed. Obviously, this did not affect T4N0 disease, but this definitely shows that lymphadenectomy is essential to also increase the survival. We know that there are various forms of lymphatic spread of gallbladder carcinoma. The least common is in the form of free DNA or RNA, and also the fact that probably gallbladder carcinoma induces some sort of tumor microenvironment changes in the lymph node, which allows these free genetic material to let micrometastasis or tumor recurrence to occur. But obviously, the most common is in the form of tumor cells, which spread via the lymphatic drainages. There are 3 different pathways which have been found after numerous studies as to how the lymphatic drainages of the lymph nodes occur. And if we see the frequency of positive lymph node location that has been described in the literature, it does show that it kind of follows this lymphatic drainage, because as you can see, the cystic duct node and the pericholedochal nodes are the first, most commonly to be involved, followed by the periportal hepatic arteries node. So it kind of follows the lymphatic drainage. So our extent of lymph node should definitely include the lymph nodes which are frequently involved by the tumors. But how about, does the location of lymph node affect the survival? Actually, there are numerous studies to show that probably the location of the lymph node actually does not have prognostic significance. In fact, these changes were incorporated in the 8th edition of AJCC, which showed that when they used the end stage based on the location, they found that there was better stratification of patients in the higher stages. When we talk about number, which was included in the end staging of AJCSC 8, we're actually talking about 3 different node counts. The first is the total lymph node count, which means positive, negative, all the nodes that have been retrieved. Second is the positive lymph node count, and third is the lymph node ratio. The total, in this article, you can see that no matter the stage of the disease, in any stage of the disease, the more the number of total lymph node count was retrieved, the survival increased. 1 year, 5 year, overall survival, cancer-specific survival was increased. So it basically showed the importance of total lymph node count. Here in this article, they showed that more the total lymph node count, more is the positive lymph node count yield, and probably because more positive lymph nodes are found, maybe it decreases the tumor burden, and so probably the total lymph node count is important. In the other graph, you can see that the group A is this, I don't know if I can, this line here is of those patients who had node negative disease, but also the group B also had node negative disease, but there was a considerable difference in their survival, mainly because patients in group A had more than 6 total lymph node count yield compared to group B, who was node negative, but yet the node count was less than 6. So There are various cutoff values given by a number of articles, but what we follow is that the minimum total lymph node count should be 6 as recommended by 8th AGCC edition. But the problem is here that there is difference in what is preached and what is actually being practiced. There's only few articles which are actually compliant with the number of total lymph node count yield. Lee et al. In 2018 showed that only 12.4% of the article even today have more than 6 lymph node count, meaning most of the patients do not have more than 6 lymph node count as recommended. The reason could be that there are very few nodes in the hepatoduodenal ligament, but it could also be because of the lack of awareness of the new consensus guidelines amongst the surgeons and pathologists. The other node count is the positive lymph node count, and obviously expected. Whenever the positive node count increases, it is associated with worsening disease-free survival. Again, various minimum node counts, positive lymph node counts have been described, and we don't know how to use it actually in the operative setting. So because of the inherent issues with the node count, Negi et al., they described the lymph node ratio, which is basically a ratio of the positive lymph node count by the total lymph node count. At a cutoff of 0.5, when 3 groups were seen, they found that as the lymph node ratio increased, the disease-free survival worsened. But they also saw that it also depended on the total lymph node count yield. As you can see in the first 2 ratios, the lymph node ratio 0 and less than 0.5, it really mattered if the total lymph node count was more than 6 or not. But it actually did not matter whether the lymph node ratio was more than 0.5 because these were likely to be a little more aggressive disease. So even with the lymph node ratio, it seems total lymph node count is still important. Of course, a lot of comparisons have been done to show which count is the best. Like this article shows that the positive lymph node count is important. This shows the lymph node ratio is more significant to us. This again shows lymph node ratio is important. So I think Saharan et al., they came up with an entirely different thought that probably what we should look at is whether or not lymph node ratio actually benefits in theoretical platforms. So this thought, if the patient has higher incidence, the probability of the incidence of lymph node metastasis is high, then these are the patients who are going to benefit with lymphadenectomy. So they made a therapeutic index, which was based on a product of incidence of lymph node metastasis and 3-year overall survival. And they basically, what it refers to is that if the therapeutic index is high, the benefit of lymphadenectomy is higher and therefore is recommended. Like in the table, you can see there are a list of patients, different cohorts which have highest therapeutic index and therefore higher likelihood of benefiting lymphadenectomy. But all in all, it seems that more the total lymph node count is very essential, though the practical scenario is a little different. So coming to the extent of lymphadenectomy, if there was a sentinel lymph node which could be described in carcinoma gallbladder, it would actually save us in dissecting the downstream lymph nodes. And if at all there were one, it would have to be a cystic duct node. And this was what was hypothesized by this article. But unfortunately, they saw that in most groups, just because cystic duct node was negative did not mean that the distal nodes were negative. There were a lot of skipped lymph node metastasis, meaning even if the cystic duct node was negative, there could be downstream positive nodes. Except for this case, which was a T2 patients with the peritoneal side tumors, where when it was a negative cystic duct node, the distal would also be negative. So it doesn't appear that sentinel lymph node still holds true for us. And obviously, like I said, the other nodes are the nodes which are mostly involved in CHGB, and that has to be included. The superior mesenteric, celiac, and retropancreatic, posterior superior pancreaticoduodenal nodes are basically described as classically described as distant metastasis, but there's a lot of discussion on posterior superior pancreaticoduodenal nodes. Moreover, these days, this is basically treated as N1 because a lot of literature have shown that instead of acting like a metastatic disease, posterior superior pancreaticoduodenal nodes more likely act like a N1, and therefore it is mostly should be included in the extent of our lymphadenectomy. The para-aortic nodes and the intra-aortic cable nodes are the final abdominal lymph nodes in the pathway, and articles basically show that whenever they are positive, they are equivalent to distant metastasis and very poor prognosis. And it seems that the preoperative evaluation is not very good at picking up these nodes, and therefore what is recommended is a frozen section before starting a curative resection, which can, in 18% of cases, avoid any futile radical surgery. So AJCC basically says this: the region A is the portion of which requires to be, the nodes of this region needs to be removed. The Japanese Society describes that region A and region B should be removed, and UICC 8 describes that all three regions should be, dissection should be done. And when it was compared, it was seen that nodes in region C, they act like distant metastases, and therefore is not recommended for it is not recommended to do a dissection for these nodes. Obviously, more the region is dissected for lymph nodes, more the total lymph node count, but the effect on survival also has to be seen. So as of now, it seems that our extent of dissection is region A and region B. Extrahepatic bile duct invasion can occur in various forms, like in type 1, where there is direct spread. In type 2, there is continuous intramural spread. In type 3, there is non-contiguous metastatic spread. In type 4, where the metastatic lymph nodes, the cancer cells from metastatic lymph nodes are permeating. Obviously, whenever there is bile duct invasion, it has very poor prognosis, and in most settings, I think all surgeons would consider that type 1 and type 2 would actually require a extrahepatic bile duct resection. But more Japanese article, mostly Japanese article, they recommend that for reasons like type 3 and type 4, and for reasons like, there could be ischemic biliary stricture after aggressive periductal nodal dissection, extrahepatic bile duct resection is recommended. There are few literatures to support extrahepatic bile duct resection, but a lot more to actually refute the benefit. Pancreaticoduodenectomy would actually definitely increase the number of lymph nodes yield, but actually does not have prognostic significance except in select cases where node is negative, but there is no infiltration. So to conclude, I'd like to say that T1B or greater gallbladder cancer requires lymph node dissection. R0 resection with lymph node dissection is paramount. Larger the total lymph node count, the better the stratification and better the outcome. And of course, the extent of node dissection as of now seems to be up till the posterior superior pancreatic duodenal node. Thank you.